It's funny that you say that because I was literally just thinking about when I was in nursing school and I was learning how to do a head to toe assessment. And my professor was like, yeah, like once you get this down, you'll probably do it in 10 minutes. And I was like, what? No way. Like, freaking out. So, okay, this is real life head to toe assessment. Starting with the head, neurologically, you ask your patient if they can talk, what's your name and date of birth? Who's the president right now? Do you know where you are? Do you know what happened? If they're intubated and they can't talk, can you squeeze my hands? Can you follow these commands? Can you wiggle your toes? Can you show me 2 fingers? Moving on to pupils, you shine the light. Are they equal and reactive? What's the size, etc.? Next is heart and lungs. Are their lungs clear, diminished, coarse? Is their heart making the classic lub-dub, S1, S2, or is it doing something funky? Then I like to move on to pulses. Radial, DPs, +2, solid, +1, thready. Sometimes you have to get the Doppler out. And then when I'm down by the feet to check strength, I tell them, okay, push like you're pressing on the gas. Okay, now pull your toes up towards your nose. And then I put my hand, on the top of their foot and feel their strength. It's a scale 1 to 5. I also like to squeeze on their legs to check for any swelling. Of course, depending on what the patient's actual diagnosis is, you'll tweak and tailor this assessment. And depending on the diagnosis, you might have to do an assessment more frequently. For example, if your patient is a TBI, you're probably going to be doing Q1 neuro checks. Or if your patient just had a vascular surgery, you're probably going to be doing Q1 hour or Q2 hour vascular checks. So on and so forth. Then I like to move on to my lines. Do they flush? Do they draw back? Where are they? If you have an arterial line or a CVP, this would be the time that you zero them. Always, always, always trace any continuous drips you have back to the pump and verify the rate. That's like one of the first things that I do when I start my shift. That's, I think, one of the first things you should do starting your shift. Like before you even touch the patient, make sure the meds are good. And then if the patient has any additional drains or lines, like an NG tube, now's the time to measure that. If they're intubated, you check what centimeter marking the tube is at, either by their teeth or lips or tongue if they don't have any teeth. If they can talk, ask them if they're having any pain. That's like one of the first things I like to ask because I like my patients to be comfortable. Who wants to be uncomfortable? The hospital is already uncomfortable enough. And if you're in the ICU, you're already probably in a lot of pain. And if they're intubated, you're relying more heavily on vital signs. Like, are they tachycardic? Are they tachypnic? Are they wincing? All of those things would be a sign that your intubated patient is in pain. Let me know if you have any questions.